Good morning, good evening, wherever you are in the world. It's my pleasure to be here with you this morning. It is morning for me. It's a beautiful sunny fall morning here in Waterloo. And if anybody doesn't know where that is, it's about an hour and a half west of Toronto. It's my great pleasure to be sharing some information with you about how to best manage your patients in the myopic space. So your patients really do deserve the best care, and I'm hoping to share some of that information with you today. Just as by means of financial disclosures, you can see them on the screen there. And any instrumentation I mention or products, certainly there is no intention on my part to endorse specific products or companies. So when we think about myopia, I know you've probably heard this 1,000 times or more. We need to think about why myopia is an issue around the world. And if we think about prevalence of myopia, in 2010, the prevalence was thought to be around about 28% of the world population, with, of course, the very well-known prediction that by 2050, nearly 50% of the world population will be affected by myopia. And that's estimated at 4.7 billion myopes, so plenty of patients for us to manage in our clinical practices. And the big concern, of course, is the increase in high myopia that's associated with that overall increase in prevalence. And it's predicted to be almost 10% of the population will be affected by high myopia in 2050. So what does that mean for your patients, and what does that mean for the individual? Well, it means that the higher the prescription, the greater the risk of vision impairment later in life. So when we look at the table here, if you're a patient who is over -6, then your risk of having retinal detachment is 20 times that of somebody who is not myopic, and the risk of myopic maculopathy, which of course can be absolutely devastating, is up at 40%. So your patients with high myopia really are at a great risk. And many of you, I'm sure, will have heard this. This is Mark Bullimore came up with the little slogan that every diopter matters. And the reason that that's the case is because with every additional diopter, we have an increased associated risk of vision problems such as myopic maculopathy, a 58% increased risk with every single diopter. So when we're thinking about myopia management, even a little bit of help can go a long way in reducing those risks later on. So even if you reduce the overall prescription by a diopter, so you slow progression down and you achieve a final result that's a diopter less than it would have been, you're still doing a lot for your patient. And when we think about the impact of lower myopia, and this is one of those things, I'm going to pause kind of on this slide for a second or two, because this is how I describe the need for myopia management to my patients and my parents. So why do I want to introduce myopia management, and why do I want to have that child have a lower prescription? Parents often think, well, I'm a high prescription, I've worn glasses all my life. Why is that an issue? So the impact of having lower prescriptions, the obvious one, less visual disability when uncorrected. And I usually give an example of if your child's in a swimming pool and they're splashing around and they're a -2 myope, they can pretty much function. They can see their friends, they can see their parents, they can see the side of the pool, they can see the lifeguard telling them that they need to move to the shallow end. If they're a -4 myope, not so much. Better outcomes and options for surgical myopia correction, so for laser vision correction. And this one I find really resonates with parents, and also reduce risk of visual impairment, so the risk of those problems later in life. So those are my kind of 3 go-tos when I'm explaining to a parent why they need to enter into myopia management for their child. What we need to do, of course, is assess the risk. So when we have a patient in the chair, even if they're not myopic, we need to assess their risk of becoming myopic and then manage that accordingly. Parental myopia is a big one. We know that the gene pool from which the child came from has a big influence on them in all sorts of ways. But certainly if you have a parent that's myopic or two parents who are myopic, that child is more at risk. To your patient in the chair, we need to think about their risk factors. And patients with high myopia, their children are more likely to also be high myopes if we don't intervene. This is really the big one that we know has the greatest influence on the likelihood of a child becoming myopic. And we can think about it as a hyperopic reserve. So how much hyperopia does that child have that they can grow out of and not become myopic, or grow out of and become myopic? And this is some work that was done back in 2015, but really holds firm today, that those children with lower amounts of hyperopia than we expect are more at risk of developing myopia. And you can see the numbers there. So if you have a 6-year-old who has less than 0.75 diopters of hyperopia, they are at risk of developing myopia. I was just at a conference, the International Myopia Conference, a couple of weeks ago, and there's suggestion there that maybe these numbers need to be a little bit bigger. So maybe the hyperopic reserve needs to be a little bit more than even these numbers are telling us. But given what we have at the moment, if you have a low hyperope, they are at risk. And those are patients we need to manage from the get-go. And I'll talk about that a little bit more in a little while. Other risk factors, children who do a lot of near work have been shown to be more myopic, more likely to be myopic than those that don't. So near work can be a risk factor. We should be asking our patients how much time they spend reading and looking at those shorter working distances as being a potential risk for myopic prevalence with children. Screen time, and this is of course a big one. We know that our children are on digital devices way more than they ever were in the past. And there's some good evidence that those children that spend more time on screens are more likely to be myopic than those that spend less time. There's a couple of studies here, one out of Asia and one out of Europe. The European one, greater than 4 hours a day of screen time, increased likelihood of being myopic, compared to those children spending less than an hour. And of course, it's not that the screens are emitting something that is creating myopia. It's that fixed working distance for extended periods of time. And I'm sure you've all seen, so there's a little picture bottom right. This was a vacation I was on. Little kiddie at lunch with his iPad, his chicken nuggets, his drink, and he did not move from that position for probably close on an hour. He didn't even look up, speak to his parents. He was head down, playing on his iPad. Increased time outside. This is one of the ones we know can delay the onset of myopia. So really good evidence that those children that spend more time outside are less likely to be myopic than those that are spending less time. Even just an hour extra per week has been shown to reduce the prevalence of myopia. So we recommend somewhere between 90 and 120 minutes per day. And in some jurisdictions, in some countries, this has actually been introduced into school curriculum. So outside time has actually been mandated as something that children need to spend time doing. Now, why do we want to delay that onset of myopia? So you can see the graph here. It's kind of a busy screen, but it's actually very straightforward and very simple. If we look at all children in this graph starting at being a -1 myope, if you start at age 8, so on the far left, and we do nothing, there's no intervention, then the final prescription at age 17 is going to be somewhere around -6 or -7. If you start with your myopia journey at age 12, for example, then you're likely to end up as perhaps a -3 myope. So delaying that onset can have an impact on final prescription, which obviously can have an impact on risks later in life. So if we think about myopia management, how do we define it? There's not really a good definition, but if we think about what myopia management means, and we talk about myopia management and we talk about myopia control, that's kind of interchangeable, but I like to think of management as being the whole process right from prior to being myopic through to when children become myopic. So we can think of provision of appropriate management or advice to patients who are A, at risk of developing myopia in terms of their lifestyle and parental myopia. Those who then become pre-myopes, so they have less hyperopic reserve than age norms. So now we can say they've started their myopic journey. And then, of course, the patients who are already myopic, how we intervene with myopia control options, and they may be optical or pharmacological. So it's that whole journey, checking the risk, looking at the ones who are already pre-myopic, and then those patients who are myopic. So when we think about our pre-myopic or our at-risk patients, really it's about educating the parents. And the first education is that children need to have an eye examination. So we need to examine those patients to see what their risks are. We need to think about limiting non-academic screen time. So those children who are spending their social time on screens, we need to think about advising minimal screen time. Of course, more time spent outside can be preventative or delay that onset. And then those children who are avid bookworms, let's limit the non-academic close work and look at that working distance. Let's get children to hold things a little bit further away, take plenty of breaks. So when we think about examining our patients, so what are the essentials that we need to do? So cycloplegic examination is absolutely essential. Some practitioners will cycloplege every single patient. It's entirely up to you, depends where you are in the world, what your access to cycloplegic options are. But certainly we know that non-cycloplegic refraction measurements are likely to be more myopic. So somewhere around half to a diopter more myopic for myopic children. More variability for our emmetropic and hyperopic children, possibly even up to close on 2 diopters, less hyperopia for our hyperopes. So you really do want to, at some point, do a good cycloplegic examination to really find out what your baseline is. We need to do a good binocular vision assessment because if we do have binocular vision issues, then these need to be addressed alongside the myopia management, and axial length measurement is becoming more essential. I'll talk about that in a little more detail. So axial length does give us the full story about myopia. We know that a millimeter of change is equivalent to about 2 diopters. A typical axial length in infancy is around about 16.5 millimeters, and that grows to being an adult length eye at about 23.5 millimeters. So we do expect axial length change from infancy through to adult years. We expect that change to be quite rapid in our under 8s at about 0.2 millimeters per year, and then that reduces to about 0.1 millimeter a year from kind of 9 onwards. The peak rate of axial elongation actually occurs 2 to 3 years prior to the onset of myopia. So if we are able to measure axial length and we see a rapid increase, then that child is already on their myopia journey. They have started to become myopic, even if their refractive error is not demonstrating that. An axial length of just over 23 millimeters for a 6 to 7-year-old, so that's like an adult length eye at 6 or 7, is also indicative of future myopia development. And a change of 0.74 across a 3-year time period before the patient is myopic suggests future development as well. So there are telltale signs if we measure axial length. Now, even those of us that have access to axial length measure tend to do it on our myopic patients. We're not tending to measure axial length on patients who are not myopic, but maybe we should be. Maybe we should be making that part of our data set of clinical tests for children. And what do we do with that information? Well, we can compare to normative data, and we can obviously look at change over time, as I have just mentioned. Now, when we think about normative data, we have two big data sets that are available in the literature. There's a couple of Asian data sets, and there is a good solid European data set, and this is it on the screen here. Again, something that you can look at kind of at your leisure. I'm not going to go over it in great detail, but we think about axial length in terms of percentiles. So where is that child in relation to where we expect them to be for their age? And to give you an example of how we use the graphs here, so we're going to give you a male patient. Scenario number one, he's got an axial length of 24 millimeters. So we plot that age and 24, and then we look, and he's actually on the 90th percentile. So he has basically a 30% chance of being myopic right now, an 87% chance of being myopic as an adult, and a 9% chance of having high myopia. So if we do nothing with him and we leave him on this trajectory, that's the prediction. Now, if his axial length was 22 millimeters as a 10-year-old, there is no myopia and basically no risk. So plotting your patient kind of against age norms really gives you some indication. And this can help with explaining to parents as well as to why you want to intervene. You can say, look, your child is on the 90th percentile, which means he is really galloping along on a myopia journey. Let's see if we can slow that down and perhaps drop him down to a 75th percentile, maybe even a 50th percentile, and get him into a less risky position for future vision impairment. So I'm sure some of you are thinking, well, that's great. She's talking about axial length, but I can't measure axial length. I don't have an instrument. And that's very common in clinical practice. What can you do? You can consider referral to a colleague, maybe a cataract surgeon locally, and just ask them as a fee for service, either the patient pays or you pay them and the patient pays you, that they measure the axial length for you. Typically, we look at axial length on an annual basis. And, is it better to ask somebody else to provide the measure than not have it at all? Something for you to consider. There are some calculation options and estimations of axial length. There's some software. This is just one example here where you can plug in the information that you have. So you'll plug in your keratometry, your refractive error, and there will be a prediction of axial length that you can perhaps use for your patient. There's also been in the literature some suggestion about calculating using conventional optometric measures again. The conclusion from this paper was that this gives a good estimation of absolute axial length, but perhaps isn't quite accurate enough for monitoring over time. But if you wanted a baseline, then you could consider looking at this paper and perhaps trying to calculate what your baseline axial length is. So having decided that our patient, needs management, we've talked about the pre-myope, so we've talked about explaining why it's important. So look at those options as to why it's important, explaining to the parent. We've looked at our pre-myope, so let's try and delay the onset. But now when we have a patient who is myopic in our chair, how are we going to manage them? So this comes down to the sort of myopia control, and this is where that word control and management is sort of interchangeable. We know there's three basic options: the spectacles, pharmaceuticals, and of course, contact lenses. How do we choose which one to go for? And dependent on where you are in the world, you may have access to one or two of the options. You may have access to all of the options. So here in Canada, we are very fortunate. We have access to everything. So when it comes to choosing, we have that discussion with the parents and of course with the child. So what's the child's lifestyle? What do they like to spend their time doing? Are they avid athletes? Are they somebody that just likes to kind of hang out at home and chill in their social life, just watch TV? Are they avid bookworms? What are they like as a person, as a personality? Are they very outgoing? Are they very shy? Do you think they would manage with one option better than the other? What's the parental preference, sorry. So what do they think that they are going to choose for their child? And to some extent, and we can't forget that the patient also needs to be part of this conversation. What do they think they would prefer? And I've had patients that straight away go, oh, I want glasses. I've had others that say, I'd really like to try contact lenses, or others that say, well, maybe I can look at both options. So have that discussion and see what you think is going to work best. Ultimately, the one that works is the one that they are going to wear or use. So that's the one that you should be recommending. Which one are they going to be compliant with? You also want to think about using evidence-based interventions. So you want to look to the literature, look to your sales reps, look at what's out there that has good, solid clinical evidence. And we know that not all evidence is equal. So when we look at this evidence pyramid, we have right at the top, like the strongest, powerful evidence is the systematic reviews of randomized controlled trials. So somebody has done the work for you. They have done the clinical trial, they have spent the millions of dollars, and they've come up with data for you to be able to use to satisfy yourself that whatever you choose is appropriate for the child. Right down at the bottom, editorials and expert opinions. Now, those shouldn't be discounted by any means, and of course, there's everything in between, but you need to think about the product you're using. Is it backed by good scientific evidence? And how do we evaluate that? Well, you can look at the length of the clinical trial. The IMI report back in 2019 recommended 3 years of clinical data. Now, whether that's still true today or not, we've just had some information published earlier this year from Noel Brennan and Mark Bullimore saying that 3-year efficacy can be predicted from 1-year data. So is a 1-year study sufficient? Is 1-year data enough for you to make your decision? We can think about those shorter trials. We can think about the control group. I think as we move forward, we're going to see clinical trials that perhaps don't have a conventional control, because it's really not ethical anymore to put children in a non-myopia control option for a clinical study, because we know that they can do better with other products. So think about the evidence and how you're going to use that. So let's go through the options. I'm not going to go into detail specifically about each option in terms of efficacy, that type of thing. That's really for another day. The purpose of this is to try and get you on board with how to make those clinical decisions. So when we think about spectacles, what should we not do? We shouldn't be undercorrecting. Progressive lenses really don't play a good role in myopia management anymore, as do bifocals. So really we can do so much better than progressive lenses or bifocals, and we know that undercorrection is not a good option for our myopic patients. So we can do way better than those 3 options. So in this table here, I've really just put the kind of the big manufacturers worldwide, their products that are on the market and that are backed by good clinical and scientific evidence. I know that depending on where you are in the world, there are other options available. So this is not necessarily exhaustive, but these are the kind of the big players in the market and the ones that we have some really solid evidence. So we have MyoSmart, Stellest, the MySight sight glass spectacles, and the MyoCare. So Hoya, Essilor, CooperVision, and Zeiss, all represented here, all with good sound evidence. And in terms of, if you're going to ask me one of the questions, well, which one is better? When you look at the data from all of them, there's some very long-term data. Hoya has 6-year data. Zeiss only at the moment has 1-year data. But all of the data looks really sound and really solid. And these are all good options for your patients. And if you haven't used myopia control spectacles on your patients yet, and you're looking at these pictures and thinking, oh my gosh, that's going to be really strange visually for the patient, I can assure you that kiddies wear them without any issue whatsoever and don't even notice that the spectacle lenses are what I call special, that they create this defocus or this reduction in contrast. Children just don't notice it at all. Well, contact lenses, what options do we have? And again, children get on remarkably well with contact lenses. Certainly, when you look at the clinical studies that have been done, most of the studies, the children are either 7 or 8 when they start with, that's the youngest age. And certainly my experience is that age can easily handle contact lenses with the appropriate, obviously, teaching and, of course, patience with them as they're learning the technique. Ortho-K, of course, is very, very popular, has been around literally for decades. It wasn't initially for myopia control. It was to eliminate the myopic prescription. And in fact, the first ever Ortho-K patient that I fit, which was way, way back in the late 80s, was actually a helicopter pilot who needed better uncorrected acuity than he was achieving. So that gives you a sense of how long Ortho-K has been around. It, of course, eliminates the need for optical correction during the day. So this circles back to lifestyle. If you have a competitive swimmer, for example, who is in the pool at 5:30 every morning prior to going to school for their swim training, maybe Ortho-K is a good option for them because that eliminates the need for that optical correction. You do require specific equipment and skills. It's not something you can just pick up and start without some appropriate training. You do need to be able to measure topography. And of course, axial length for our Ortho-K patients is really important because we're not measuring change in refractive error because there is no refractive error. Overnight wear, are there increased risks minimally? Yes, a little bit of an increased risk, but that's something that you need to discuss and consider with the parents. Within the realm of our soft lenses, we have distance center multifocals. There's various options from lots of manufacturers there. Extended depth of focus, the natural view multifocal lens is the main player there. There is another one that's the Mark Envoy lens that's available in Australia. Dual focus, the MySight lens has the longest clinical data on with the longest clinical trial, similar to the spectacle lens option where you have kind of 6 or 7 years of data. And then the newest one, the ring boost technology from J&J, the AccuView Ability, that has some very early clinical data that has been presented at conferences. So you've got various options that you can consider with your patients if they're interested in a soft lens option. When we think about pharmaceuticals, the main player, of course, is atropine. And atropine comes in various concentrations, and there's a little bit of controversy about the best concentration to use, and I'll talk about that in just a second. But there are other options. So some data that was just published, actually published again at the IMC meeting that I was just at, this 7MX, which is a caffeine-based oral medication that has some promising results. Just at the moment available in Europe. I haven't seen it anywhere else in the world, but it certainly looks like we might be getting other pharmaceutical options coming onto the market in the future. So when we think about atropine, which at the moment is the main player, what concentration are you going to choose? And there's many studies, and in fact, 2 were just published in the last little while that kind of ran in parallel. I don't think either study knew that the other was necessarily running when they started it. There was the CHAMP study and the PEDIG MTS1 trial, both looking at various concentrations, and the kind of overarching results and the take-home message from the CHAMP study was that 0.01% is effective in myopia control. The PEDIG study, their conclusion was that 0.01% was ineffective. So you have a little bit of controversial results there. If we look at the LAMP study, which is a much longer study and really looked at all sorts of options of children who were in one concentration and switched to another, they were in a higher concentration or lower concentration, children came out of atropine, they stayed in atropine. It was a massive, massive study. The 5-year data that they have published, basically their take-home message is that 0.05% is likely the most effective concentration. And certainly clinically, I start with 0.05%. If a child struggles with side effects from that, I'm happy to drop down to 0.025%, but I wouldn't make 0.01% my starting point if atropine was my chosen method of myopia control. You also need to think about what's in the bottle. So at the moment, there's not many options for commercially available atropine. I think in Asia, there are some single-use vials for 0.01%. But if we look at compounding pharmacies and what they produce for your atropine patients, a great paper here from Catherine Richdale looking at samples of atropine from 9 compounding pharmacies and found that there's a huge variation. So some recommended refrigeration, some didn't. Some said the beyond use dates were 2 weeks to 6 months. Some were from solutions, some were from powder. And then, of course, the active or the inactive ingredients, sorry, in the bottle. What's in there? Is it saline? Is it artificial tears? What preservatives do you have? So there is a little bit of a mystery, kind of a mystery bottle when you're having atropine compounded. And that's just something that we need to think about with our patients. So something else that's been kind of gaining in popularity, repeated low-level red light therapy, commercially available in 12 countries. So this particular product, 650 nanometer, it's a laser product administered at home under parental supervision. Very, very promising, 3 minutes a day, twice a day, 5 days a week. So super, super easy to use, although interestingly, there was a paper published or presented, sorry, at the same conference I was just talking about, and it was looking at a group of patients in the UK, and actually the compliance with using the instrument was quite poor. So that patients forgot, they couldn't be bothered, they kind of lost interest. So even though it's short time per day, it doesn't necessarily mean you get good compliance. So very promising results, but there are some concerns, and the concerns are really about the safety. So the output of this particular laser does exceed the American National Standards Institute classification, and the amount of light that the retina is getting does depend on viewing time and pupil size. So children with larger pupils are getting perhaps an overdose compared to children with lower pupils. And my understanding is this has actually just been reclassified in China as a class 3 laser, which means that it's actually not readily available to optometrists anymore. So I think great potential, but a lot more work needed to look at that safety and look at the ideal time to use per patient. There's some exciting work coming out about other light therapies, so perhaps a little less scary because they're not laser treatments. So there's a proof of concept trial on the Myopia X this is in the UK, I believe, blue light use, so blue light stimulation to control myopia via dopamine modulation. And we know that, or one of the theories about spending time outside is that outdoor time and sunlight actually promotes the production of dopamine, which modulates axial length growth. So this is very promising. They have some proof of concept data and very promising 6-month results. And I think their 1-year results will probably see published or presented maybe early next year. So something to look out for, other light therapy options that may be coming through onto the market. So what about combination therapies? This is something that gets asked all the time. Should I be adding in something with, well, typically a pharmaceutical with an optical correction? And we have some really good data. So atropine and ortho-K, some data suggests that combination therapy may be better than ortho-K alone, possibly greater impact on children with low myopia, and maybe greater impact in the first 6 to 12 months, and then perhaps not so much after that. So is it a good thing to do? I think if you have a young low myope who is at risk of fast progression or who has demonstrated fast progression already. So maybe they were a -1 and now you've put them in ortho-K and suddenly they're still like their axial length is showing them to be closer to a -150 equivalent. You've had that increase. Maybe you've had 0.2 millimeters of axial length increase and you were only kind of hoping for 0.1. Then maybe you've got nothing to lose by adding in atropine to that patient. The Blink study that looked at the soft multifocals that came up with the high ad is the best option. They also had an arm of the study that they had atropine with the soft multifocal, and actually found that there was no increased benefit by adding atropine in. No detriment, but no increased benefit. Some good work on atropine plus spectacles. So a couple of studies here, one using 0.01, one using 0.025, and both came up with that there was an advantage of having atropine and the spectacle lens. This particular one was the DIMS, the MyoSmart, that the children with that combination therapy did progress less than the ones just with the spectacles alone. So I think there's some good evidence, and certainly what I do in clinical practice is the young fast progressors or the early onset, I tend to hit them hard from the get-go. So let's throw everything at it initially, because if we can slow down the progression right from the beginning, then we give them a better chance. So we know that they're going to progress for quite some time. So let's really do everything we can to put the brakes on. The other thing about introducing atropine into a patient who's wearing spectacles or contact lenses is if for some reason they're not wearing their optical correction, and we find this with our young low myopes who we put into spectacles, not infrequently they take their spectacles off, and because they're a low myope, they don't necessarily need them visually. It comes back to what I said right at the beginning about being less visually disabled without your correction. So they take the glasses off. Maybe they're going out at recess and they're kicking a soccer ball around the field. Glasses come off, go in the backpack or stay on the desk, and then they forget to put them back on. So if you have atropine as well, you've kind of got some coverage from two different directions, working in two different ways, and hopefully that child is always in some sort of myopia control option, even if they're not necessarily using both at the same time. And we know that atropine, although it's supposed to be every day of the week, it gets forgotten. So, bedtime suddenly becomes late and the kid can't be bothered to put the drops in, or mum forgets, or mum's out and dad forgets, or dad's out, mum forgets. So again, combination therapies can give you that sort of coverage from two different directions. So when do we start with myopia control? Well, as soon as there is evidence of myopia or pre-myopia with our cycloplegic refraction, we need to have those discussions, or we need to intervene. Depends on age of onset, look at the risk factors, look at the axial length, have those discussions early on, have those lifestyle discussions, reduce screen time, more time outside. Don't wait for progression to be demonstrated. Children will progress. It's very rare that they don't, and we don't want to wait for progression. Now, with that said, you may have no choice, because if a parent is not on board at the beginning, either they're skeptical, it's financial, whatever reason it is, if they're not on board, you may need to wait until there is progression, and then you can say, here we are, look, this has moved from here to here, we need to intervene. So I would encourage you to see your patients maybe a little more regularly than you perhaps would have done. So if you have, a 7-year-old who is right on plano, no refractive error, have them back in 6 months. Because if the needle has switched, just budged towards being myopic, then you can have that discussion again. You may need to have it again in 6 months. You may need to have it 6 months after that, but you're planting the seed, and the parent is now going to be more on board when they are ready, when they see that shift. When do we stop? So this is not okay, we're going to put your child in these glasses, in these contact lenses using atropine for 2 years. This is an ongoing commitment. So we know that by 16, about 50% of myopes have stabilized, which of course means that 50% are still progressing. Now, progression slows down dramatically. So the progression that you see in an 8, 9, 10-year-old is way more than you see in a 14 or 15-year-old. But we don't want to stop until we're sure that the myopia has stopped progressing. With that said, if you stop at, say, 13 because you think things are stable, and then you see the child again and the myopia has galloped along a little bit, then you can always reintroduce a myopia control option. What about rebound? What happens when we stop? Do we expect that that child is just going to gallop along to where they would have been had we never done anything? This paper literally published a couple of months ago, so it's out in June. Again, Mark Bullimore and Noel Brennan, who have done some awesome work in the myopia control space. No evidence of rebound for myopia control spectacles or contact lenses. So if you take a child out of those optical options, no evidence of rebound. Higher levels of atropine, so this was 0.1%, so not 0.01 that we're talking about 0.1%. So high concentrations of atropine, you do get significant rebound, and there's been evidence of rebound on the red light therapy. Stop the red light therapy, the eye gallops to where it would have been potentially. So think about rebound. Obviously, if the myopia journey is over, so the child is 16 or 17, you're not going to get rebound. But if your child is 10 or 11 and you take them out, then what do we expect? We don't expect the myopia control impact to stay, but we would expect the child to continue progression at the rate they would have done, not to gallop to where they would have been had you done nothing. So what do you do if it doesn't work or you think it's not working? So it's really important that you monitor for efficacy. So that's with our refractive error and axial length. You need to confirm compliance. Is the child wearing those glasses all day for at least 10 to 12 hours? Are they taking them off at recess and forgetting to put them back on? If compliance is an issue, then consider changing modality to something that they are going to be more compliant with. Consider a combination therapy for the reasons that I've just mentioned a couple of slides ago. Maybe add something else in so you've got coverage in different directions. Can we do something prophylactically? Can we look at our children at risk and say, you know what, maybe we should do something? Well, optically, really, we can't, because we're not going to put a hyperopic child in a myopia control spectacle. The LAMP study again has come out with some data on using low concentration atropine as a prophylactic treatment, so 0.05% in children without myopia. And it did result in a lower incidence of myopia by about 50%. So kind of a 50-50 chance if you put your child on atropine prior to them becoming myopic, whether that will delay the onset or actually eliminate the onset. So more work needs to be done on this. But if you have a child who is really at risk, maybe you have two highly myopic parents, then perhaps you might consider this or have that conversation with them. So wrapping up, myopia control is standard of care in some countries. So here in Canada, it's been standard of care now for a couple of years. That's our Canadian Association. But what I would say to you, no matter where you are in the world, it really is your duty of care to manage your patients appropriately. So in all countries, myopia control should be considered as duty of care. Interesting question. So why is myopia advancing in adults who were children with myopia even after 23 to 24 years? So is near activity a risk? That's a great question. And we do see our young adults, particularly like our university students, we do see that increase in myopia. It doesn't tend to gallop, but we do see some increase. There is no good evidence on using myopia control options in adults, but that doesn't mean you can't. So if you have an adult that's progressing, maybe you want to consider putting them in a myopia control option. I think you have nothing to lose and you potentially have something to gain. In terms of which is the best option for our patients, the one they're going to use, spectacle lenses, is there a better one? Somebody's asking specifically which one is the better one. I think there's good evidence with all of them. Some have longer evidence. So some you've got some 6-year data, some you've got 1-year data. But I think it's up to you to choose which one you want to go with. I think they all have some very good evidence behind them. Do contact lenses benefit high myopia? They do optically, of course, because the contact lens is going to give a probably a better optical outcome. So you don't have the aberrations of the lenses and obviously the restrictions of a spectacle lens. So you might find visually you get a better outcome. But in terms of myopia control, there's really no benefit over one option to another. So somebody's asking me about the role of peripheral refraction in myopia. Peripheral refraction is gaining more interest, and there's some thoughts about children with myopic peripheral refraction or hyperopic peripheral refraction may be more or less well served by certain optical corrections. It's really not mainstream to measure peripheral refraction, and we don't have instrumentation to measure it accurately. So in a clinical, in a research setting, we kind of set up an open field autorefractor and then measure peripheral refraction. But I think in the clinical setting at this point in time, we're really not considering peripheral refraction, something really for the research space. How to manage progressive myopia in a young child. So the suggestion is age 3 to 5. Again, I think you have to manage it in the same way as you would a 6 or 7-year-old. The research data is, 7 to 8 or whatever the study is and upwards. Some of the spectacle data is, I think, 6-year-olds, but you have to do something. Now, a very young, very high myope, you might want to look a little more deeply into where the myopia is coming from. So that may be more of a syndrome than kind of a conventional myopia. So if you have a 3-year-old who's a -12 myope, that's not your normal progressing myope. That's something different. And you might want to work with a geneticist or an ophthalmologist or both to see if you can find out what's going on there. And of course, with very high myopes, we're limited with our products that are available as to what will go up to that amount of prescription. So the very young, very high myopes tend to be a different category altogether. Are spectacles effective alone? Absolutely. For many, many patients, a spectacle option works beautifully. As I say, it's the younger, fast progressors that we might want to think about combination therapy. You might not. You might be more than happy just going with spectacles, but the data is solid that it is a very good option as a standalone, provided the child is compliant and that they wear them. How will the caffeine in the medication affect children in other areas of life? Heaven knows. The data that's published hasn't really talked much about that. I mean, it's hard to imagine it doesn't have an impact. I mean, these are quite high doses. It's like 400 milligrams 3 times a day. So there's a lot of work still needs to be done. And we'll just have to kind of watch this space and see what comes out there. Similar question about young children with myopia control. Is it necessary for children under 5? If you have a 4-year-old who's a -1 myope, you need to get on that straight away. If you have a 4-year-old who's a -10 myope, that's different. But 4-year-old, 5-year-olds, anybody can be myopic. And we are seeing an earlier age. I'm certainly seeing it in clinical practice. I'm sure you are, that children are starting to be myopic at a much younger age, and we need to really jump on that. So somebody asking about the cost of glasses. Yes, they cost more, but also most of the companies, if not all of them, they offer a warranty period such that if the prescription changes by a certain amount in a certain length of time, they will change those spectacle lenses free of charge. So you have to work out, maybe the initial outlay is a little bit more, but if that myopia doesn't progress and they don't end up buying another pair of spectacles in 6 or 9 months and then another one 6 or 9 months after that, perhaps they end up spending about the same over a 2-year time period. So initial outlay more for sure, but maybe in the long term, the outlay is similar. So why choosing 0.05% atropine instead of 0.01? I think I mentioned that the 0.01 has not been shown to necessarily be as effective, and the 0.05 has been shown to be more effective. And I think if you're giving atropine as your choice of option for a standalone, you want to go to that higher concentration. Now, the combination therapies, the data published has been on adding 0.01% to the spectacle lenses or the contact lens option. Do I add 0.01%? No, I hit it hard and I add 0.05%, unless the child can't tolerate that, either from pupil size or accommodation, and then I would drop it down. But if I'm going to hit it hard, I'm hitting it hard because I want the maximum control. You can never go back. You can never go, oh gosh, look at you, you've progressed by a doctor. I wish I had been more aggressive. So I think be aggressive from the outset, and you can drop back later. You can take the atropine away maybe after a year or 2 years. So hit it hard and do the best you can. Is myopia control effective for patients with high genetic factors for myopia? Yes. The genetic risk kind of creates the myopia, and the myopia control like modulates the ocular response. So it's about trying to tell the eye, I know you want to get longer because you've got this genetic factor, but I'm going to give you signals to stop growing. So that's the myopic the defocus or the dopamine or whatever the mechanism of action is. It's to interrupt that signal to keep growing. When should we stop using atropine, and at what age should we taper? That is a great question. We don't have a lot of long-term data on atropine. So there's nothing published at the moment on children who have perhaps been using atropine for 8 or 10 years. Personally, from my opinion, I think atropine is a relatively short term. And in the short term, I'm talking perhaps 2 to 3 years. And then I think you're outside of perhaps that really dangerous zone of the fast progression. So perhaps your child is now 10 or 11 and you can go to just an optical correction and maybe drop the atropine. Some evidence that tapering is better for rebound, but now we have some work done that says there isn't really any rebound with the lower concentrations. So I think you can do a hard stop or you could do a soft taper, and it probably doesn't matter. Glasses for over 18, again, no data, nothing's published, but nothing to lose and potentially something to gain. So if you have a progressing myope in their young adult years, put them in a myopia control option, and maybe you will just slow it down that little bit more. Can normal spectacles help with myopia control? 1000% not. A regular single vision spectacle lens is going to do nothing at all apart from give the child good vision. It's going to do nothing for myopia control. Another question about atropine. These happen all the time. So somebody's saying, what about if you have a 13-year-old who's -5 and has never been treated before? I because if we circle all the way back to every diopter matters, if you can slow that progression down, so he's -5 now, he's probably not going to be a -10 myope if he's already 13, but he might be a -6 or a -650. If you can slow down progression so he becomes only a -525 or a -550, you've done some good. He's still a high myope, but you've done a little bit to reduce that risk of vision impairment later in life. So absolutely, you should do something. There's another one in a language. I'm so sorry. I do wish I was multilingual. I consider myself multilingual. I'm actually British, so I speak British English and Canadian English, but that's as bilingual as I get. So again, a 16-year-old who is still progressing, would you consider myopia control? Absolutely. So when to stop atropine, we've covered that one. Percentage of success in inhibiting the progression of myopia. Good. I mean, I can't give you a number. You can look at all the clinical studies to see what the impact was for specific products, but it works. So I can tell you from a scientific perspective, from a theoretical perspective, from sitting in conferences, listening to presentations, but I can tell you from boots on the ground. I work 2 days a week in clinic, pediatric clinic, seeing children, and myopia control works. Whatever you pick, it is going to be an advantage for your patient, and you should do it. Your patients deserve it. And as a practitioner, with the knowledge that you have, it is your duty of care to offer. Even if the parents say no, you are managing the myopia by having the discussion. So absolutely, yes, you have to. So how do you identify children genetically predisposed? Typically, it's from the parents or the child. I mean, if we're talking about the very high myopes, there may be a syndrome there. The child may have something else going on that predisposes them to high myopia. But the family history and the lifestyle are the two big ones that you really want to delve into. And ask the questions. How much screen time is your child doing? And parents love it when you tell their child that they shouldn't be on their screens as much. They are looking to you to parent their children for them sometimes. Another question, oldest age you'd recommend myopia control. No age limit in my world, certainly within the children and adolescent years. Those young myopes, if you're seeing progression or a later onset. So you've got a 20-year-old that suddenly becomes a -1 myope, maybe they're a university student, then that patient should be offered the option. And in fact, we did a study recently looking at a myopia control option with young adults. And one of the questions at the end was, if this could slow down your myopia, would you purchase it? And I think it was 75% said yes, absolutely. So patients are interested if there's something that they can do to slow down progression. Any contraindications using special myopia control glasses? None whatsoever. Children don't even know that they're wearing anything different. I mean, their vision is corrected, so they see better. And even if there were some peripheral distortion, peripheral contrast, peripheral defocus, kiddies just don't notice it. They don't, in the same ways they don't notice when half their breakfast is over one of their spectacle lenses and you look at them and you think, how can you possibly see out of that? They just don't notice. How many hours does the child need to have the protection? So again, looking at the data, those children in one particular study who wore their spectacles 12 hours a day compared to less than 12 hours had a better impact on their myopia progression. So basically it's all day, but 10 to 12 hours is your absolute minimum. Best age to start with atropine. I think we've covered that and covered when to stop. So you have to decide if it's your only modality you're using, then, if you have a child who's maybe a half diopter myope and an optical correction is just not an option and you choose atropine, then that would be your standalone. Ideally, they would wear an optical correction as well, but you may not be able to convince a 7-year-old to wear half a diopter of correction in a spectacle lens or a contact lens. So maybe atropine is your only option as a starting point. Um, We've talked about that. Another one, translation of the Spanish question, do you have experience using atropine drops to stop the progression of myopia? We've talked about that, yes. So again, another good option with some great data. When do we stop atropine? When do we stop anything? Again, kind of covered that. You probably want to keep going until your early teens, mid-teens maybe. And why stop? If there's no issue from the patient, if they're coping very well with whatever their modality is, why would you stop until you're 1,000% sure that the myopia has really plateaued and isn't changing? So how does atropine work? We don't actually know. We have some theories, but we don't really know why atropine slows down progression, but we know that it does. So sometimes you just have to go with that. Children older than 12, we've covered that. Oh, management for unilateral progressing myopia. So that's an interesting one. If you have a unilateral myope, then probably a contact lens is your best option. They are not the easiest ones to manage, but they're fortunately not super, super common. Rebound, we've talked about that with atropine, not really any rebound with the 0.05%. So a good question, if you were to use atropine prophylactically, how long do you continue? Again, we don't have enough data yet. So that one is something that we're kind of watching this space to see what the recommendations are. Repeated, the low-level red light therapy, it depends on your jurisdiction as to where it's available. So you'll have to look and see whether it's available in your country, and then you make your decision whether you're comfortable with the safety profile. So combination therapy, we've covered that. Can visual acuity be affected by atropine? So you're going to get pupils a little bit larger and possibly some impact on accommodation. So that's something you just need to manage with your child. You may need to put them into a photochromic spectacle lens, which is, they're readily available within the myopia control spectacles as well. So if you're doing combination therapy, you might want to put them in a photochromic spectacle lens to give them that extra help outside in the daylight. But generally speaking, children manage quite well. And if they're really struggling, then you can lower the concentration. Okay, I am just going to have a quick scout down the rest of the questions. We're running out of time. There's some great questions, if you have specific questions, I would encourage you to contact me directly if there's something. So you can find me at the University of Waterloo Optometry website, but my email is really easy. It's dajones@uwaterloo.ca. And maybe through this platform, we can perhaps post that so that if you have specific questions or you want to reach out to me, I'd be more than happy. Peripheral defocus. So peripheral defocus spectacles have low evidence. I think when you look at the literature, you'll see that there's some very solid evidence there. Maybe you just need to revisit that paper again. Yes, you start myopia progression control or myopic control as soon as the child is diagnosed with myopia. Absolutely. Near activities, high risk for children getting myopia, I think just extended periods of time up close. So children that are bookworms, that have their nose in their books for hours upon hours or on digital devices, are those that have been shown to more likely to progress to myopia. And I thank you all for spending your time with me. It's been my absolute pleasure. And as I say, anybody wants to reach out to me, please feel free to. And with that, I will say good night, good afternoon, or good morning to you all.